Good afternoon, everyone. We're starting fairly on time. I want to thank everyone for coming in to be with us this afternoon and for spending the day with us. And one of the reasons I asked Pastor Debbedo Brown to come and speak on mental health is one of the things that we as Adventists don't like to talk about or pretend that there's not an issue in our lives. During COVID, I had a traumatic thing happen to me when I was, that was during the lockdown, and I didn't know who to talk to explain what had happened to me and just to have somebody listen to me or hear me. And I did this test online to see if I needed to go consult with someone that could help me. And my results of the test came back, said, you need to find somebody immediately. And I said, oh no. So I was looking around for someone, and I couldn't find anyone. And so what I did was I was on the phone with my middle sister at the time, at one night, and she kept asking me, Bev, what happened to you? What was it? What's going on? And I just couldn't talk to her. I couldn't talk to anybody. Couldn't talk to the pastor at the time, nothing. So my sister said, why don't you call Pastor Tony? He was a pastor at Kinderhook Church at the time. She said, he's a registered psychologist. I said, what? And I was praying and asking God to help me find somebody. I was trying to find somebody online and everything, but everybody was booked up. It was hard. So she said, why don't you talk to Pastor Tony? He's a registered psychologist, and he'll make room for you. So I emailed Pastor Tony, and I told him I was trying to find somebody to talk to because something very traumatizing had happened. And Pastor Tony said, Bev, I'll take you right away. So I would meet with Pastor Tony 6:30 in the morning before I started work. I was an online teacher at the time. And my first meeting with Pastor Tony, everything came out of my mouth like a river. Just everything just flowed right out. And after that was over, I was like, whew, I just felt this weight taken off of my shoulder. And Pastor Tony said, Bev, you've been dealing with this for how long? He said, how long? I said, Pastor Tony, I didn't know who to talk to. And he said, and still going to church and worshiping God and everything, and you've been dealing with this for how long? And I just was frozen. I said, I didn't know who to go to. It's like you don't want anybody telling all your business. And it's just hard to find. I said, and sometimes when you're on the phone talking to somebody and you take a little time talking, they're quick to hang up on you. I said, I just didn't know who to talk to. And sometimes people just say, bring it to Jesus, but sometimes you need somebody to sit down and talk to. So Pastor Tony met with me every week for a while, and he said, God is going to bless you. He said, because you've been through a lot, and he said, you got something, he has something for you to do. He said, I don't know what it is. He said, but whatever it is big because you went through all of this. And that talking with Pastor Tony helped me tremendously. So I want to say to anybody who may be facing something traumatic in your life, seek help. It's out there. And one of the things I was looking for, I asked God, I said, I needed Christian guidance, Christian help. And he was a pastor, and he was able to speak to me and help me through what was going on and using the Bible and things like that and natural medicines and things like that to talk about what was happening to me, and it helped a lot. So if you're going through something, don't be afraid to contact somebody and talk to them. Let us pray. Dear Heavenly Father, thank you so very much for the day we have spent with you. I appreciate your bringing Pastor Brown into our paths, into my path, and that we can begin to talk about these things that so many of us like to hide away. But I thank you for the guidance and his direction and how to be have peace according to Philippians, and all that you do. And we remember that you, Jesus, are the ultimate giver of peace. Thank you for all that you do for us, and thank you for the day. We love you, God. We love you, Jesus. We love you, Holy Spirit, and our guardian angels. In Jesus' name I pray. Amen.
Thank you so very much, Sister Beverly, for sharing that testimony. That's that's one of the burdens we want to share with our brothers and sisters, that if you are going through a challenging period, it is important, yes, to pray, but it is also important to seek a space that is safe, where you are able to communicate with somebody and have them, in a corroborative way, work through whatever is going on, because we have seen where that has been extremely therapeutic and transformative. So thank you for sharing that testimony. Just a little bit more, I was assigned to one of the things that triggered my interest. And then my wife is going to share with you very briefly her history in this field. But one of the things that triggered my interest in the field of mental health, I recognized that as a pastor, I was preaching and praying and studying. But then there were some people who weren't experiencing the profound changes. And so I said, there has to be something else that I need as a minister to work with these individuals. And that's when I decided, instead of doing all my degrees in theology, I went back and I pursued clinical social work. And so I praise the Lord that I was able to get that added skill, and it has been a complementary piece to what we do, as ministers. And I find that this additional piece has really benefited individuals that we work with, not only in the church, but also outside of the church. So as you heard in the introduction this morning, in addition to being a ordained, trained pastor, I am also a trained, licensed clinical social worker. My wife will just share a little bit about her expertise in this field.
So I am also a licensed clinical social worker. I have been in the field for over 15 years. I've worked in outpatient mental health, domestic violence. I have a background in forensics as well. I hopefully, in the next coming months, I am going to be also defending my dissertation. I'll be defending for my PhD in clinical psychology. My topic, I'm looking at fathers who have kids who experience suicidality.
All right. So the core of our presentation this afternoon is to try to bring some awareness, not only regarding the importance of seeking help, even though we are Christians, even though we serve the Lord, even though we come and we worship every single Sabbath. It is critical to know that there is no dichotomy between having a relationship with Jesus and seeking a safe space to address certain things that we are going through. So that's one awareness. There's nothing contradictory with your faith when it comes on to that. Number two is particularly to share that, hey, when it comes on to the clinical experience with black and brown communities, it can look different as opposed to perhaps in a Caucasian community as opposed to perhaps a Haitian community. All right? And therefore, the approaches will have to be different. All right? So we want to share that. But we want it to be a little interactive, so I'm hoping you're able to see it on the screen. And so my wife will ask you this question, and if you know the answer or you want to attempt, you please feel free.
So as you see on the screen, what is the percentage of African Americans that seek mental health treatment compared to their white counterparts? So compared to whites, what's the percentage, do you think, of African Americans that seek mental health treatment? 10%? 80%? You mean 80% African American? Ooh. 30%? 18? 1%.
Okay. Well, some of you came pretty close.
Pretty close.
Very, very close. So let's see what we have on the screen.
So as you see, blacks are far less likely to seek mental health treatment. So only 25% of African Americans tend to seek compared to 40% of whites. That's a 15% disparity.
Hold the mic up to you. Oh. So you see that's a 15% gap, right? Now, when we go through the presentation, you're going to see why there is this widened gap and how we can close this gap. But one of the things that I have to also share is that our white counterparts tend, of course, there is some privilege there. You have to also say there is access there as well, which those are factors in the black and brown community. But then there is another piece that you cannot overlook. They recognize how beneficial therapy can be, and so they take advantage of it. So that's also another reason why you have this widening gap. Now, one of the things the Lord has laid upon our hearts, whether in our private life or in my role as health ministries director in the conference, is asking the question, what can we do to close this gap between our community and our white counterparts? Because we are seeing that we would love to see more of our color taking advantage of talking with somebody when they are going through depression. So one of the things we are doing personally is, we have opened this private practice, and 99% of the people we see are Caribbean blacks, Hispanics, and African Americans, okay? So we are trying to solve one of the problems of the individuals in our community being able to find therapists who they can culturally connect with in therapy, all right? So that's one of the things we are trying to do as it relates to closing this gap that exists between our black counterparts, Hispanic counterparts, and white counterparts.
So in the same way, there's a disparity amongst blacks who seek. When it comes to professionals, black professionals, there is also a lack. So what percentage of counseling professionals do you think are black compared to when you compare it to white professionals?
10%.
10%?
Any other guess? Oh, we hearing some mumbling. You have to shout it out.
So 20%, you think 20% are blacks? Okay.
30%? I heard somebody said what now? 12%?
5%. So you're the one that's coming the closest.
All right.
So it's about 2%. So of the 41,000 like psychiatrists and psychologists registered, the APA is reporting it's about 2%. One of the other things that we've seen, because it's not just psychologists, you have social workers, you have mental health counselors. When it comes to the black community, yes, they might have the degree, but in order to practice in the therapeutic space, you have to be board certified, you have to have the licensure, you have to would have gotten the supervision under somebody who is able to supervise you for the state to say, yes, you could go now sit the boards. And what we find is that people in our black community, they have the degree, and that's it. So they often work in spaces that they don't develop the expertise to provide psychotherapy. Mm-hmm. And so what we've been doing, along with providing access to culturally competent therapists, we also have, we've partnered with 3 universities so far, and we have an internship program where we're training interns as well to help them to actually work with our community. One of the other things that we've been doing is trying to work with our black and brown therapists who don't have licensure, so we can provide them the supervision and the support so that they can also get licensed. We have had, we have a clinician who, she's been in the field for 16 years, been trying to get the license, the first license, because with social work there's multiple phases, and couldn't pass the exam because there's a certain level of, when it comes to supervision, you're supposed to be supervised in a certain way. So when you actually take the boards, you can actually pass it. And she started with us January of last year, and before the year end, I think it took her 8 months, and she's now licensed. So those are some of the things that we're doing to ensure that, more and more clinicians are out there to service our community.
Yep. And so as my wife said, we are trying to contribute to this disparity by providing access where, the black and brown population can come for that cultural, clinical experience. But not only that, we are trying to put out therapists out there to meet the black and brown demand for therapy. As a matter of fact, we have one Seventh-day Adventist lady who was recent. She searched high and low, just couldn't find any school who would take her. Just got a call saying, hey, a pastor told us you are operating. Can you please help me with my internship? So right now, we are working with the school to provide her with internship experience so she will be able to graduate and be able to go in the field and begin to change lives in this field. All right?
And to add, majority of our clinicians are black and brown, but we also have clinicians who are not black, they're white. But one of the things that we're also doing in that space is helping them to understand how to work with the black and brown community.
All right, depression, we have to understand, does not look the same in every culture. And so the reality is, in the black and brown communities, depression can go underdiagnosed, all right? Because as you're going to see in our presentation, there is a certain language that black and brown people use to communicate that they are depressed. There's a certain way that the body expresses depression that differ from that of our white counterpart. And sometimes the language of depression is not used. And so if the clinician sitting before you and do not hear, I am depressed, they might mislabel what you come to therapy for as something else. There are times when we see a person might be irritable, frustrated, aggressive, and it is more pathologized as opposed to the clinician looking for depression. You see what I'm saying? So that's, if you come in and they are not seeing it as depression, but they are seeing it as aggression or something else, what is happening? You are being what? Misdiagnosed. Then it is also connected to being underdiagnosed because they are mislabeling it as something else. And then there is a spiritualization part to it, right? Where sometimes people are really going through something tough. Either they personally spiritualize it away, or they are so apprehensive in sharing what they are going through with their faith community because they are going to be looked down upon as being a weak Christian or not having enough faith in God. And so here's what they do. They hide that to themselves. And as a result, it goes what? Misdiagnosed or underdiagnosed.
And misdiagnosis can seem like it might seem like simple, right? But it carries consequences. So if a person is misdiagnosed, especially in the black community, let's say there's depression, but you misdiagnose depression, oftentimes it's seen as more behavioral, it's more conduct related. And when a person is diagnosed with depression, there comes more empathy. When a person is diagnosed with more conduct related, it is criminalized. It is treated in the criminal justice system. So let's just take, for example, a kid. If a school looks at let's say a 14-year-old boy, and they said he's depressed, they are going to move towards, we need to get him a therapist, we need to do this. However, if he's diagnosed as more oppositional conduct, they are going to channel him in more behavioral things, and that eventually leads to the criminal justice system.
And, I know my wife wants to share an experience where a young man, at his job, and I'm going to allow her to share it.
So we have a gentleman that we worked with in the practice. He, at his job, he got fired, let's say. He was experiencing, his father passed, he was going through a divorce, a number of challenges that were going on for him. He went to his job, he said he needed time off. Of course, they denied it. He's in the medical field. And he went to work one day, and a patient was just getting rowdy and came at him. And you know what he did? He lost it. He attacked the patient back. And so they fired him. And when he came to us, very depressed. We worked with him, and we guided him. Because one of the things that we recognize, the black community does not understand the power of accessing mental health support. It protects your job. A white community, if something happens to them, they are in a mental health professional office, and they're getting the letter, they're getting the protection. It's the same protection as if you have a physical disability that mental health gives you. So we gave him the necessary letters to support what he was going through. Of course, he ended up winning the case. He sued them, so he has a big fat check coming. And he actually got his job back. So in his situation, at first it was dealt with punitively, but because he was able to get the right support, he was able to prove, because of your own, sometimes you cannot do that, because the way in which he responded was more aggressive, the irritability, and that's usually a conduct-related thing. But in our community, a lot of times that's how it's expressed.
A young doctor, a young nurse practitioner, young, aspiring, hardworking young man, Of course, he's disappointed how things went. You know what they were pushing him to do with all that pumped up disappointment and frustration? Just get back to work. So when he came, he said, I couldn't do it. Because I know if I went back to work immediately, I would have lost it. And you know what they're going to look at him as? A disruptive individual. But they are missing the fact that he has all this pumped up frustration, pumped up stress because of things that he's experiencing on the job, including racial discrimination. You know what he had to do? He had to get the necessary mental health support to take a break. And by taking a break, he's now in a confidential space where he can get all of that thing out, process everything, so that when he goes back, his job is not in jeopardy because that was let out somewhere else. It's not let out on the job. Are you understanding what I'm saying? You see what I'm saying? And so that is why it is so important that we help our black and brown people to know what's going on inside of them and try not to push beyond the body's limit, and to know that this is something I need to address. Because when that comes out on your job, it can go in a different direction. You see what I'm saying? Are you with me so far, Saints? All right. All right.
All right. So depression is rarely openly discussed in our community, yet the suffering is profoundly real. We suffer in silence. The gap between the lived experience and the clinical recognition is not a matter of biology. It is a product of systemic neglect, cultural misunderstanding, and historical wounds. I'm sure if I ask for a raise of hands, a lot of us here today could raise our hands and say, hey, we've experienced like discrimination and things like that, microaggression in the workplace. Because oftentimes what is the way in which the black, we are interpreted in the workplace is different from how we're seen compared to our white counterparts. And let me give you an example. I'm going to use myself. I worked I was in a forensic space, and so I was working with boys who commit serious crimes, right? Murder, you name it. And of course, because the response, the way they respond to things towards the black is different than how they respond to our white counterparts. So the white social worker went to see this young man. He threatened her. What do you think they did? She was removed. Who do you think they called? Me. He threatened to rape me, kill me. Do you think I was removed? No. Because I should be able to do it. And oftentimes you have, even if you're in a nurse, sometimes they call you to deal with the worst cases. So you have the worst kind of trauma, but the response and the support is not there.
All right. So as we move on, it says the data on depression in Black and Hispanic communities reveal a troubling paradox. Low rates of diagnosed depression exist alongside higher rates of chronic, severe, and disabling forms of illness. And why, for me, I believe it's not lower, but it's because, again, it's being misdiagnosed. It's because, again, it is going underreported. And it's because, again, there are barriers preventing Black and brown people to go and seek treatment. So all of those factors are affecting the numbers. But I believe if the real numbers were supposed to be revealed, it would be far higher. All right? And notice that the science is saying that when it's really manifested among us, it is very severe, it is very chronic, and it's very sustained. Why? Because there are times when we take a long, long time before we go and seek the help that we need to seek. So we are there suffering with this thing quite a bit in silence. And then later down, you're going to see it's not something you want to really toy with, because it can escalate to other things.
All right. So we know when mental health is not dealt with, there's some severe consequences, right? We recognize that the suicide rate, over the past 20 years, the suicide rate among Black youths have increased drastically. I work with my job prior to going into my own practice was working with middle school and adolescents who attempted suicide. And so stabilize them to get them back into the community. You know, we were, on average, I would say per month, we probably got, we were able to have 16 kids at one time. And of those 16 kids, maybe 1 or 2 would be white, but everybody else was Black or Hispanic, right? A 2014 study found that 49% of Black women who were in primary care setting endorsed symptoms of depression. And of that 49%, 10% were experiencing suicidal thoughts. When I was doing the research for my dissertation, found that 1 in 3 people think about suicide. So if you are 3 people standing together, 1 of you have thought about something about suicide, death, or stuff like that. It is very prevalent. We found that Black high schoolers report suicidal thoughts at 9.8% compared to a 6.1% of white students. Big difference. Also between 1991 and 2017, there was a decrease in suicide rate among teens, but a 73% rise among Black teens, while we had a decrease among white teens. Look at the numbers. And there's a lot of reasons for this. You know, I'm gonna pause and put something out there. In our Black community, when our kids come to us and they say, hey, I'm feeling depressed, count it a privilege, get them help. And there's a family that kind of reached out to us for help. Couldn't work with them because we're not licensed in the state that they're in. But we did give some support. I assessed the kid and I gave them my professional feedback. And I can tell you, the kid has still not gotten the help that she needs. She had attempted suicide 3 times, and the parents could verify that she had attempted suicide 3 times. When I met with her, through our conversation, I discovered that she was cutting when you look at her skin. And there were some places that she couldn't show me because what kids do, sometimes if they know they don't want you to see, they'll cut their groin area. So it's not always that you as a parent can see. But some kids do cut their arms, but there are some private places that they're cutting. There were so many things. And I think, sometimes in our Black community, we try to explain it away, and these are not uneducated people. When our kids come to us, get them the help, because it can have some real consequences. Don't shoot them away and tell them, hey, what do you have to be sad about? Get them the help. There are kids who you won't tell you anything, but you notice the change in their behavior. They're not acting as they used to. Get them the help. They might not tell you, but I can tell you for a fact they will talk to somebody else, because this family, when they reached out and they were talking to me, they said, oh, we're just going to let you talk to her, but we don't know if she's going to talk to you. Let me tell you, if I could work with the kid, she would still be talking to me. She said, oh my God, it was so good talking to you. Am I going to see you again next week? So get them the help.
Yeah, that's very, very important, ladies and gentlemen, because sometimes we tell them, you're doing this for attention, or you're over-exaggerating this,
or they're demon-possessed.
Or, demon-possessed. But sometimes you have to take a step back and to say, let me err on the side of mercy here. Just could it be that what they are verbalizing is real, and I need to get them the help. So once they're asking you, as my wife says, it's really, really a privilege. When I was going to Glenmuir, my mother came to this country. I was 16 at the time, seeking a better life. She got sick over here, so that financial support wasn't coming back to Jamaica. Then my father, I didn't know him that well. I had to go and live with him. Needless to say, that wasn't a pleasant experience. And I found myself in high school, sleeping, I couldn't put my finger on what it was, but I just knew that something wasn't right. And it's when I started to look into this thing, I realized at age 16 I was severely depressed. I could sleep until thy kingdom come. And I was wondering what was going on. But it's later I recognized I was going through something. And literally heard the Spirit of God says, get up and leave that place. And I left. When I went to my aunt's house, it was a completely different experience. You see what I'm saying? And when, what, somebody would pass that off, boy, lazy, sleep too much. But I was going through a real challenge. Does that make sense, ladies and gentlemen? All right.
So to kind of put it together, start. Do you have a question?
Sure. Right. Right.
when I went into the correctional facility to work as a counselor, the inmates I met there, you know, they were suffering from alcoholism. I don't know how much you deal with that in your practice, because, I mean, you know, it's a disease that is not really partial in any way. It doesn't matter whether you're white or black. Alcoholism is something that we take pride in cover. And, you know, we that were brought up in fear and ignorance, yeah, we who are really brought up in fear and ignorance, we lost our way, many of us, when we turned to alcohol. I am a recovered alcoholic, right? And, you know, you make a few points there where, you know, we inherit a lot of labels, where people label us and start feeding us with other drugs. You know, I was really brought up, you know, to respect people and so forth. So when I went into jail, inmate questioned to me, have you ever been to jail? No, I was never arrested in my life. Not in my life. I'm 91 years old, actually, and I never been arrested in my life, but for the grace of God and good parenting, all right? So, you know, I listen to them because, you know, in the training I get at the university, they teach me that I should learn to listen and listen to learn. So it was the inmates that really educate me, all right? Because most of these people that was labeled depression and whatever you may call it,
Yeah.
and feed with drugs, they end up in the institution. When I walk in, you were talking about statistics.
Sure.
When I went into Rikers Island jail in 1965, all right, to really carry the message to the inmates, there was a drunken CO at the desk. I could smell him from a distance, from I got off the ferry, all right? And we were all decked out, you know, all dressed up because the esteem was so low at that time, all right? And how he introduced us was, here come the bumps, all right? So it gave me the courage to challenge the system.
Sure.
And when I apply for a license, we apply, a group of us that was sober and recovering, we apply for a license.
Sure.
They only gave us a credential. Okay, so that's the system we're working.
Yes.
We have to face it.
Yes.
Our people are not educated enough because, you know, this word pride.
Right.
There's another side of pride. It's called
Sure.
ignorance
Yeah.
or whatever. So, you know, when we talk about white and black,
Yeah.
all right, this is the challenge that a lot of us is having today, separation,
Right.
divide and conquer nonsense. Okay, I just want to
No, I appreciate you for
Share
sharing
that.
that, and you know, and as you asked the question, if we do focus on addiction in our practice, yeah, we do have clinicians who the CASAC, and they basically work with individuals who are going through addiction as well. But we appreciate you sharing that. All right, so on the screen, as you see there, 50% in the black and brown community, they are less likely to receive care. They are 3 more times chronic severity and early dropout. And one of the things we are recognizing in terms of early dropout is connection with the clinician, connectivity with the clinician. So one of the things that I'm saying this very, very sensitively, because I have to be pragmatic and realistic because we live in a real world. One of the things we realize is that sometimes people from the black and brown community come, and the first thing when they come, because my face, my wife's face, right there on the website and the practice. And the first thing they say to us, they say, listen, I want you to understand that I'm not a racist person. I do not have a racist bone in me. But one thing I'm asking you, please can you connect me with a clinician of color, all right? And a clinician of color. Now, why? Sometimes when you probe that, they would say, I did try the other side of therapy in terms of trying, but there was a misunderstanding there. There was not that cultural connectivity there. And that is one of the reasons I didn't bother go back, you see? So that's very, very, very critical for our community as it relates to seeking therapy. I get it time and time and time after time.
And to add to the dropout, sometimes it's not just the cultural piece, but one of the things that we are hearing a lot from clients that when we do the consultations is that sometimes their white sometimes the white clinician will say to them, I can't help you, because there's so much the issues are so intertwined, and there's so much that they're coming with. It requires an intimate understanding of cultural nuances, also being able to separate out these issues, knowing which one to work with first, knowing the family, the cultural and the family things, how to do it. So sometimes, and then the trauma, like in our black community, there's so much trauma. And so working through all of that, sometimes they say, hey, I just can't help you. And the client leaves discouraged. And when they come to us, they're saying, hey, can you even help me? Because my last clinician said they can't help me. And so if the clinician feels despair, like I can't help you, even if they don't say it, the client actually feels that in therapy, that, listen, I can't help you. So they just drop out. They don't come back.
Yep. All right. So as we have been saying, there is a systemic stress where people in our communities are suffering from depression, historical trauma, and then there is the cultural expression that you are going to see. It requires intentional focus to look at the language that is being used when somebody sit before you in therapy.
And understanding it also, it's not biology, again, it's context. It's not that the black and brown community are more resilient to depression. The problem is that the system is less equipped to see it. And that equitable care begins with understanding that clinical tools were never developed for us. They were never developed. So if you go, a lot of assessments that are there to diagnose depression, they were not developed for us. So a lot of times with the cultural nuances, with the loaded language, coded language that we come with, it just misses depression, and it looks like conduct.
Yeah. So if you think about it in practical terms, if you have a a screw that requires a Phillips screwdriver, you can't go there with a flathead screwdriver. You're not going to get anywhere. Does that make sense? So, if you're trying to use the clinical tools that were developed for another cultural group and force it in another population, you might not get anywhere with that. All right? And that is one of the reasons now they are trying to rethink this thing. You literally right now have clinicians working on developing culturally based therapeutic models to match our population because they realize it's a concern. So let's look at the black communities and the language. When I am fine means nothing but that I'm fine. So you might not have a black person or a Hispanic person coming into therapy and say, I am depressed, using that word depression, right? Instead, you got to listen for the coded language that signals deep distress beneath the surface. These phrases carry the weight of suffering that has no clinical name. And we're going to show you what the DSM classifies depression as and how people in our community use language to relate how they are depressed. So for example, in the black communities, cultural language might be, I am tired, not necessarily I am depressed. I am stressed, not necessarily I'm depressed. I'm going through, not necessarily I'm depressed. I just need to pray more. I can't be weak. I'm not built for therapy. So these are some of the cultural languages that are used in conveying depression in our community as opposed to outrightly saying, I am depressed. One young lady who basically went to the doctor did everything, can't find anything, and said, Desi, you need to go and talk to a therapist. But while I'm doing the assessment with her, I recognized she kept on using irritability. She said, I'm just not a very nice person. But that word keeps just surfacing. And that's when I provided her with psychoeducation that, hey, it's possible that irritability can be linked to when I said that to her, you could see that there was a light bulb that went off in her head because of so many things that she was struggling with. It was creating that pressure, and that pressure was manifesting itself in irritability. You see what I'm saying? I see a hand there. So can somebody pass that mic to... So are you understanding? I don't want this piece to be missed. Are you understanding that the language depression might not be used, but there are cultural expressions that you got to look out for? Does that make any sense?
You've been emphasizing, and rightly so, the cultural, reality of black and brown not seeking therapy. But for many of us in this room, we have another challenge, and it's probably the third point on the board there, in that as Christians, we are taught just to pray about it. Right. And you're probably dealing with this because of the absence of faith, and we run to the Bible, and people send us to the Bible, go read, go study, go pray. So we are less likely to seek therapy because we are cultured, not just black and brown, but as Christians, to pray about everything. How do we balance the two? The need to pray more and the need to get help when we are taught that prayer will solve everything. We don't need to go get no therapy because you need to just pray and have faith.
So one of the things that I always tell my clients, because a lot of times they come into the consultation and sometimes they're like, oh, I'm fine, but my doctor sent me. We get a lot of referrals from the primary care physician. And I'll say to them, the Bible doesn't contradict itself. Let's say you have, when I read the Bible, it says if you're sick, seek a physician. And mental health
Hey,
is
I'm
no
in church.
mental health is no different from diabetes. If you realize you're having some physical symptoms, you go to the doctor, and the doctor says XYZ, and you're gonna follow up, and you're gonna keep following up with the doctor till the doctor says you're okay, right? And mental health is no different. It is the same thing. The same laws that protect you for physical illnesses, it's the same laws that protect you when it comes to mental health. There's no difference. And if the Bible says if you're sick, seek a physician, it applies to mental health as well.
Yes, yes, and that's important too, because there's a statement Ellen White makes. She says 9/10 of the disease from which men suffer have their origin in the mind. All right, so we are very cognizant that we can stand here and we could lecture you to death. But if let's say you are dealing with overweight, and I'm coming back to the spiritual piece in a little bit, but let's say you are dealing with overweight and you are using food as your coping mechanism because you're responding to a traumatic experience. You know, I can lecture you to death and never get anywhere. But if I sit with you and journey through that, bring you back as to what the source of the trauma is, I would develop a goal. You get better success that way. Some people going to hear and make the changes, but others, this side is very needed to help them to make the changes. When it comes on to the spiritual piece, that is one of the reasons why the church has to say, yes, we are providing a space for prayer. Yes, we are providing a space for Bible study. But we are also providing a space that if you are going through something, we have a referral part for you to go and seek professional. So while we are praying, we are also becoming pragmatic in seeking the help. You know, what we are trying to make sure we have a sensitive balance between determination and distress. So, while, you know, where we are saying, okay, we want you to pray, we want you to study the Bible. Yeah, we are doing our best to encourage you spiritually, because some people are doing their best with the knowledge that they know, and we understand that piece. All right? However, what we don't want is that the other side is taken away, where we say, hey, while you're trying to pray through it, or while you're trying to get some encouragement from the Word, you have this additional support that God has also ordained that you can capitalize on. Pastor Coleman pastors this church of several of you. When you look at how you think he's going to take on, let's say you have even 10 people, or you think he's going to take on some serious things that he can offer pastoral support, but then there are some things where he might have to say, hey, you want to sit with a professional to work through this. And I was at Mamre, and in the pastoral work, some people come, it would take me quite some months, and that's just one case. And you're sitting before 300 and something people. So we have to have a referral path for them to go and seek additional support and help.
And,
Right.
and to give you an example of how mental health is so intertwined with health, just this week, I have a 47-year-old woman that I've been working with. We've been working together for this April, so about a year now. And she said to me, oh, you know, Shelly, and I want you to know I'm completely off my blood pressure medication, my cholesterol is fine. So she was just telling me she went to the doctor and whatever, and it's been, she says, oh, this has been consistent for a couple months now. And so as we're there talking, she's kind of connecting and saying to me, she recognized that once she started therapy, the doctor started decreasing her blood pressure medication, and now she's off. She was getting sick, not because of that something's wrong with her. When you look at her, she exercises, she does a lot of things, but at the same time, she was struggling with depression, struggling with anxiety, and that was kind of converging. And now, we are having a conversation of saying, maybe you don't need me no more. And that's when you're seeing those improvement in health as well. So these are some of the typical symptoms that you'll find when someone is struggling with depression, right? Self-criticism, inability to fall asleep or stay asleep. So you might find yourself waking up really early in the morning, or you just can't sleep. It takes you hours to fall asleep. You're eating more, or you're eating too little. Dissociating. So people kind of check out a reality. You will find for teenagers, even some adults now, they just completely immerse themselves in the games and have no sense of what reality is. Or you might find people starting just overworking, so to the point where they're not really focusing or being present. Having thoughts of death, and it might not be, oh, I'm going to kill myself, but you might think about, what if I wasn't here? Nobody will miss me. It can seem more passive. Doesn't have to be active where you're thinking about, killing yourself. Thoughts of just not being good enough, feelings of not doing enough, because of course when you're depressed, you don't have as much energy, so you find them, they're thinking about, I'm just not doing enough. Again, you're going to have that irritability, restlessness, feelings of worthlessness or excessive guilt, sometimes over things that really you don't need to feel that guilty about. One of the other things you're going to find, sexual dysfunction or libido, and this is not age-related. We work with 20-something-year-olds who are having significant sexual dysfunction, not because anything is wrong with them physically, because they've been to the doctor and the doctor says nothing's wrong with you. And now the doctor is sending them to us because it's not a medical thing, it's a mental health issue. And with depression, you do experience low libido, which most people might not be thinking about, but then you see it in your relationship where one party is complaining that, this person doesn't want to have sex or things like that. And the person is saying, I just don't feel like it. And then, of course, you're going to have some relationship difficulties, especially in the Black and brown community, because they're not seeking help. So you might have a lot of arguments, not just surrounding sex, but just because there's a level of irritability. So you have problems with your kids, problems with your spouse. So these are some of the typical symptoms that you're going to see.
All right, so some of the, clinical takeaway, what we want to do, if the language of expressing depression is different in our community, then guess what happened? We got to focus on that. Instead of asking, do you feel depressed? We might want to ask, hey, are you tired in a way that sleep doesn't fix? And you might get a better, people start to share some things more. Because if you say, are you depressed? They might say, no, I'm not depressed. But remember again, they use a language that is different to convey depression. Does that make sense, everybody? All right. Now, so there is not only a language way of expressing depression, and we're going to speed it up a little bit, but there are also somatic symptoms in our community that reveal depression. All right?
All right, so in Black communities, depression is frequently presented in the body again. So you might find the tiredness, the fatigue. You're going to find them leading to repeated medical visits. So they might be going to the emergency room, might be going to their primary care physician constantly, and the doctor is saying, I just can't find the issue. And it takes months, sometimes years, before these doctors actually refer patients to a mental health professional.
Right. And so this is critical, what we are not, we anytime in the body comes with these bodily manifestation, headaches and body pain, fatigue, sleep, these are medical manifestations. One of the things we want to make sure that their doctors rule this out to say this is not a medical problem that is contributing. So we have to make sure. We don't just jump to the assumption that because you are having frequent headaches, it means you are depressed, or because you're going through fatigue, it means you are depressed. No, we want to ensure that medically there is nothing there contributing to this. But when that medical piece is ruled out, and even the doctor themselves is saying, this seems to be something that is mental, that's when you are starting to look at that, because depression again can manifest itself through these somatic symptoms. Does that make sense, everybody? All right? So that's one of the things we look for. We look for fatigue, we look for sleep disturbance, we look for aggression, we look for irritability. Because when somebody is going through something in their lives, it's not inconceivable that these would be the manifestation, some of the things that will be manifested. Does that make sense? All right.
Also, what we do really well, we mask emotions, right? And these are things that we're taught from childhood. To be strong. Don't let them see you cry, right? How many of us have been told that? Don't let them see you cry. We survived slavery. We can survive this. We can survive anything. And again, there has to be that balance between that level of determination and that survival spirit and vulnerability.
Yes.
Both can exist at the same time.
Mm-hmm. And, one gentleman, professional basketball, a professional basketball player. And this is one of the things we are seeing too. So, you might want to have a conversation with your children who are aspiring there, because there is this level of expectation that I'm going to make it to the NBA and I'm going to get a lot of money, and and when that doesn't happen, I'm telling you, one grown man was just crying. And he says, listen, forgive me for crying. I said, listen, trust me, you are showing strength by crying as opposed to showing weakness. And I have to applaud you because you come seeking help. And I said, because he was very concerned that his son. I said, man, you are modeling something priceless before your son. Now he can see you as a human being. You see what I'm saying? So this macho type thing, of course, there are times when it's useful, but when it becomes, there are some alarm bells giving off to say, hey, this can become detrimental. You need to slow down. You need to be vulnerable. You need to seek support. That's going to be very, very necessary. All right? Spiritual framing. This is where faith can be used as a shield. This is what you were talking about. Sometimes it can also be seen as a barrier. All right? And so one of the things, how depression is seen in the black and brown community, especially in the area of Christianity, sometimes it can be seen as a spiritual warfare. Sometimes it can be looked upon as a lack of faith. And there are other times when we can tell people who are going through a mental health experience that they need deliverance. And we have to be very careful, ladies and gentlemen, because, I was very, very close to somebody when I was younger. I didn't know what it was. But all I know was that that person wasn't in their rightful mind. You know, back then in Jamaica, we had what is called Bellevue. Anybody from Jamaica who know about Bellevue? There we go. Bellevue, right? And that person was losing a lot of weight. You could see redness in their eyes, and we were wondering, what's going on? It's easy at that time to say, to cast this person aside, right? So we had to make a tough choice, because that person was saying they weren't sick, but we know they were sick. That's just delusion. And we had to make a tough choice to bring that person to Bellevue, restrain that person and bring them there. When they got the medical help that they needed, there was a complete white about turn. The person was doing so well. I say, okay, I'm going to stop taking the medication now. I'm going to now try the natural part. Guess what happened? Because it was done so prematurely, the illness came back. We had to bring the person back. The person came back to their sanity. It's then that we had to have a serious conversation to say, listen, this seems that the mind, the body has reached to a place where the medication is really needed here, along with those natural lifestyle, but it's really needed here. That person came back to the United States, is a citizen now, is working quite well. But if you were buying into the thing that the person is demon possessed, you wouldn't have gotten the person the mental health support that they needed. Are you listening to what I'm saying? So let's be careful that we don't label. We're not saying satanic attack is not real. Don't get me wrong. But let's be careful that we don't label somebody as being demon possessed when all they really need is some mental health support. Does that make sense? I see a hand right here.
Right next to you.
No, it's because I don't talk. She didn't know. I just have a quick question in regards to the spiritual framing.
Yeah.
Seeing as that, someone that is starting, like if there is a person that's starting to practice their faith and to do that and to know that there's trials, how can they differentiate that that's not like what it is, that you have a lack of faith? Like how can you differentiate that it is a mental illness and that you do need to seek further help, but you're still kind of trying to learn that, hey, you should trust God, trust the process. Like that kind of just seems like it contradicts itself. Like should I just assume that I do need mental health if things are being trial? That's my question, I'm sorry.
Right. So I think what I gather from what you're saying is that there are times in the Christian path you're going through some really difficult times. Is that correct? And when do you know how to pray, trust God, read your Bible, and don't mislabel it as a mental health situation? Or when it reaches to the place where you need to say, I'm going to pray, trust God, read my Bible, but add mental health support, right? So once you start to see it's being manifested in all the things that we have been talking about here, irritability, aggression, you're talking about oversleeping, overeating, all these bodily signs, you're saying, okay, perhaps I need now not only to pray, because I've been doing that, not only to be encouraged by the service on Wednesday night and Sabbath, because I've been doing that. It might be a situation where I need to seek a confidential space and start to unload some of these things on my mind. Just like what Sister Bev says, she was going through a period, and what she recognized is that, yes, She was coming to church serving, but she needed also that additional support. That's when, as a Christian, serving the Lord, praying, she found a pastor who is also a clinician who was able to help her to get that off her chest. All right? So all the symptoms and the signs that we have shared would be something to look, and they will start to inform you. The body will start to inform you, that this might be time to seek some support.
It can also be preventative. Not to say the minute you're going through something, you're going to run to see a therapist. But if you're going through some real crucible, right, you can pray, and you can also seek a therapist. And I'm going to tell you why that's my belief. And I think my sister passed away in 2005. I was still pretty young. I'd just gone to college in my first year of college. And so this was back in Jamaica. And I remember my sister lost her baby. She was 7 months pregnant. She went to the hospital. Of course, her husband had a wandering eye and the whole 9 yards. And so that was causing some stress. She went to the hospital. They had to take the baby. She lost the baby. So you're talking about two major issues going on right here, right? She comes home. She's praying. She goes to church. Oh, my God, I don't think anybody could pray all day like she could. I remember I came home from school, of course. I'm studying psychology, right? And I come home and I said to my mom, she needs to see somebody. She needs therapy. Nobody was entertaining me. This was Jamaica back in 2004. And so my sister, what they did not know, she was also told she had cancer that day that she lost the baby. My sister died a year to the T. Not because the cancer was spread, it had not metastasized at all. All she had to do was, what do you call it? When you take out it wouldn't even have to be that yet. Yes, she would have to do a hysterectomy, and that was it. The cancer metastasized in 1 year, and she was dead because she didn't seek help. She was just praying. If she had gone to someone and they had done the necessary assessment and recognized, they would have found out that she had the cancer. She didn't tell us until, we started noticing that she was getting sick. And by then, it had spread to her kidney. There was no going back. And she died, and she left one child.
So we are not devaluing the importance of spirituality as a protective factor against depression and mental illness. That's not what we are saying. But we are saying that's because, the scientific literature is abundant in terms of how religion helps with these mental health illnesses. However, what we want you to recognize with spirituality is that it can be a genuine protective factor when the church community provides this social support, mean-making, and resilience, because research consistently shows that faith can buffer against psychological distress. But here is when it becomes a problem. However, when spiritual framing delays clinical intervention, or when individuals feel their depression is evidence of personal spiritual failure, that's when it can become a barrier. Does that make sense, everybody? All right. All right. So what we want...
So it's important that you understand that it can be preventative, just like you go to your doctor. You're going through real stuff. Seek mental health. Seeking mental health support is not contradicting to prayer.
Yeah. And by the way, I can tell you I can count on my hand how many Seventh-day Adventists we have in our practice seeking help. And some of them didn't come knowing that we are Seventh-day Adventists. It's after going through the consultation that they realize, hey, I'm a Seventh-day Adventist. What I recognize, our non-Seventh-day Adventist brothers and sisters in the other Christian community, they're eating this thing up like crazy, all right? And so they recognize, how important a space that is, all right?
And that's the importance of culturally sensitive therapy as well, because in the black and brown community, you cannot dismiss faith. Even if the person doesn't go to church, you cannot dismiss faith. There is going to be some reference of faith, and you want them to feel comfortable talking about their faith, and that's going to integrate it into the therapeutic work as well.
All right, so we have, just to make sure you understand what we have been trying to say, we have a vignette, and we are going to see if what we have been trying to say all this time was captured. All right, so my wife is going to read that.
All right, so let's take Malik. He was referred for being disrespectful, easily frustrated, aggressive during recess. His teachers report incomplete work and frequent stomach aches. At home, he has stopped enjoying basketball, wants to stay in his room, and is not himself. His family recently faced housing instability. His mother works nights, and he has experienced racial bullying at school.
Let me ask you, looking at Malik's case, what are some of the things that scream out at you that you might need to look for depression? Raise your hand. I see a hand down there. Loss of interest. Housing instability. What else? Being bullied.
And not just bullying, racial bullying.
What else? Stomachache. What else? Is parental availability. Because he's how old? 8. But mom is not there. What else? He withdraws. Okay? But, so, a culturally sensitive clinician would be taking all these things into consideration. Does that make sense? But what if the clinician is not culturally sensitive? What would be some of the things Malik will be going through that he could be diagnosed, or in the clinical experience the focus is on something else? Conduct behavior, because he was referred for being what? Disrespectful. Referred for being easily what? Frustrated. And what? Aggressive. You see what I'm saying? So I can be focusing on behavior. When Malik, because he's facing all these things as an 8-year-old child, that's how he's responding to it. So you see why it is so critical to make sure that the therapist is culturally aware of what is going on. So what we are going to do to help Malik as a culturally aware and sensitive clinician, what are some of the things we would have to do? Talk to me. Mentorship. Mentorship is important. What else? We have to try to see what support we can give to moms so moms can be available for her 8-year-old son. What else? We got to work with the school to address the what? The bullying. So it cannot be one thing we are working from. We got to work with the whole system to address and provide Malik with help. Does that make sense, ladies and gentlemen?
So let's say Malik goes before a clinician that is not culturally sensitive. Does anything in this vineyard stuck out to you that could cause issue for Malik's mom? Yes. What? There you go. Bam. And is Malik going to really get the support that he needs? No. He's going to be put under further issues because this family could be torn apart. Right? Sometimes what will also happen is that Malik will kind of just leave it out. So he won't tell because he knows it can be an issue for them. But if he does tell, it's going to cause further distress on the family.
So what we want to see is that we are not only engaging Malik in his own personal clinical journey, but we have to engage the school here. We have to engage the family here. And we also have to engage community here. And if moms is connected to a church, we have to engage the church here. Does that make sense? Because we want all these systems working together to give Malik the support that he needs. And that is why you cannot do therapy in solo. That's why we have to corroborate with other institutions. Does that make sense, ladies and gentlemen? All right, we got to move on to the other one.
Before we move on, oftentimes our black parents don't know how to advocate for their kids. Yeah. So they go to a meeting and they tell them, you know, this is what's going on with Malik, this is disciplinary. They have no clue. Sometimes I have to share with parents, like, no, you need to get an educational advocate, and here's a number, and this is who you can call, and educating them why. They don't know how much power that they have when they access these things, but a lot of times we just don't know.
All right, we're going to do another one because we want to see if you're capturing what we're trying to communicate. Another vignette, go ahead.
All right, so Jalen comes to therapy only after his girlfriend says he's become emotionally absent. He says, I'm not depressed, I'm just exhausted. He reports poor sleep, overeating, detachment, loss of interest in music, and frequent thoughts that nothing is going to change anyway. He keeps working, avoids crying, and describes repeated workplace microaggressions and pressures to appear composed and non-threatening.
All right, what are some of the things that we are looking for that scream at you? The overeating, loss of interest in music. What else? Oh, I'm glad you mentioned that. The language, I am not depressed. But there are other things going on in his life that are telling us he's what? He's depressed. You see what I'm saying? Poor sleep. And what else in the workplace? He's, right. And he's emotionally distant. And then the microaggression that he's facing at home, and he's trying to do what he's trying to do with all of this. He's trying to bottle it in so that he doesn't, but eventually if it's not dealt with, what he's trying to avoid is just going to spill over. You see what I'm saying, ladies and gentlemen? And that is why it is so important that we don't only look for the language of depression, we got to look for how it is being expressed, how it's also being manifested in the somatic symptoms. Does that make sense? All right. So what we're going to do, we're going to rush down because I think we capture some of it. And the same thing with the Hispanics is just similar. But I want to bring you to what the DSM, what you would actually see in the clinical document that you need to look for in depression and show how it is expressed in our communities absent in the clinical document.
Diagnostical Statistical Manual. So
Yeah.
it's like the the Bible for mental health diagnosis. So when you think about, like, there are certain domains that they look at, like mood, and you'll see some of the symptoms are sadness, tearfulness. In a cultural presentation in black and brown, it's not the tearfulness, it's more irritability, anger, and flatness. So the affect might be very flat.
So in the mood now, what my wife is saying in the DSM, they are saying you got to look for what? Sadness and tearfulness. But we are realizing that we can't just only look for sadness and tearfulness. We have to also look for what? Irritability, anger, and emotional flatness. But that's not in the DSM. You see what I'm saying? So we have to make sure that we have that cultural competence and understanding that we have to look for those other things. Go on.
So in the behavioral domain, of course, they say look for social withdrawal or social isolation. But you might find overworking, compulsive busyness. You might also have people over-engaging with other people just to kind of suppress it. When it comes to energy, you're saying low energy fatigue, and you're going to see in the cultural presentation just tired being attributed to work life, nothing else. And cognition, you might have hopelessness, worthlessness, but presenting in the black and brown community, again, you're going to see it as a spiritual crisis. They're going through a spiritual crisis right now, feeling abandoned by God, right? And physically, you're going to have some psychomotor changes. In the black and brown communities, a lot of somatic symptoms, headaches, body pain, gastrointestinal symptoms are what they're going to complain of.
Yeah.
So as you see, the typical symptoms, it shows up very different for us. Not only does it show up very different, it's communicated differently.
So I'm suspecting that in the near future, they would have to revise the DSM to include these other expressions. Does that make sense? All right. We're going to go to the gap. So one of the things we want to do is to remove the stigma, the lack of cultural competent providers. We want to make sure there's insurance and access gap. We want to take away the fear of being labeled. Yeah.
Let's pause at the fear of being labeled, because I find that black and Hispanics believe that if they get a diagnosis, they won't be able to do this or they won't be able to do that, and it's going to carry through for the rest of their lives and the whole 9 yards. We see people from the military. So are they being kicked out of the military? We have a lot of military people who we see, and they're diagnosed with depression, PTSD, and a host of other stuff, even bipolar disorder. Are they kicked out of the military? No, but there's a lot of times where we see people are saying they're not seeking mental health care because it's going to prevent you from being able to go into certain professions. I see, I have a client, she's an emergency medical doctor. I have a cardiologist. So, I have a criminal attorney that I see for therapy. So it doesn't, it doesn't, having a mental illness does not exclude you from a profession. It's when you do not take care of yourself, you let these, barriers come into play, and it gets worse. And then, now you're having psychiatric hospitalizations and things like that. That's what's going to keep you from being able to go into certain profession. There's a nurse practitioner that one of the clinicians were seeing, and African guy refused. The only way he came in was because his wife made him come for couples therapy because she was going to leave. But as you know, there are a lot of other things. You can't work on the unit if the other person is experiencing a mental health crisis. There needs to be some working over there before you can work on the unit. He lost his job. And then we got a call, that we had to kind of stop working with him because we're saying, hey, you have to seek individual. We needed him to be stabilized, because you can't work with someone for mental health, like doing therapy, if they're not stabilized. And we wanted him to actually refer him to a psychiatrist. He refused to go. We can't continue to work with him in the couples, because we were putting the wife at risk, because he was becoming, so when she would reveal certain things in therapy, he would become very aggressive, or he would become suicidal. After we stopped working with him, the wife continued working with a different clinician for individual therapy, and she reported that he tried to jump through a window just because he didn't seek help. And I'm sure he's probably on his way to losing his medical license if he doesn't continue to get help.
Sure. And saints, one of the things we talk about the church, because, under Pastor Daly, there was significant emphasis placed on responding to the physical diseases, diabetes, high blood pressure. And that's fine. That's important. But one of the things I'm hoping that we can extend that to start to give this attention to the mental health piece. All right? Because, as I say, there are some people who will hear about taking better care of your body, and they will do that immediately. But then there are some people who would need that space and ongoing help to reach there. I can't tell you how many people who come in ignorant. I've even now to create a budget and leave basically knowing. I can't tell you how many times I was able to get to talk to people about spiritual things who are not a part of our faith, because they came with that intention. So I'm able to actually connect them with that. I had one lady who was basically struggling whether this is God disappointing her, or she doesn't have too much faith, or what, and she was weeping and it's just gradually working with her to bring her to that place where she can begin to trust God to take care of her. So I know this thing from a practical experience is very helpful. And so the question we are asking, I know you want to say something. You want to say something? The question we are asking, what can the church do? All right, 6 ways church leaders can help to save lives in this area. We want to normalize therapy from the church perspective. We want to also share that depression is not a sin. All right? Sometimes it gets the better of us. When we look at even Elijah, and how, he had a slip in his journey, was very suicidal, right? That person would need, some support to get back there. Praise the Lord, the voice, the still small voice of the Lord was sufficient to redirect him, all right? Train health ministries leaders, making sure that this component is also added. We want to make sure that each church has a referral path. With Family Life Ministries, right now there is this compilation, because some of the members are calling up the Family Life Director, sometimes calling up the health director to give them therapy. But remember, this is a conference of how many people? Right? So that's not going to be sustainable on the directors. But if we have a referral path where people can actually put their finger on to say, hey, I can go here and get the help that I need, that would be very, very helpful. And host psychoeducation seminars. And you also want to partner with clinicians. All right, that's critical and important.
Also, have the referral pathways are so important, right? Because people with depression, even the act of finding a therapist is not only you have to find a therapist, you have to find one that takes your insurance, one that has availability, and a host and one that is culturally aware, right? So by the time, with all of those things that you have to do, it takes a little searching. And that goes against what depression is. In depression, you don't feel like you want to do anything for some people, right? You might find them overworking, but at the same time, when it comes to the stuff that they should do to seek help, they don't have the energy to do that. And so having this referral pathway will kind of help you to kind of say, hey, here you can call this person, that person. They accept your insurance. And that's going to give you better success in them actually reaching out. And if you could do it with them, go ahead. Yeah.
Yeah. Right. I see your hand, and let me just finish off and then just take all the questions. Yeah.
And the other point is, I know pastors are a good source to go to. Debbedo made the point that they can't take on everything. Also, sometimes there are certain things that you're coming to therapy with that you probably don't want to discuss with your pastors, because the poor pastor can't preach up here after that, because anything he's preaching, it's going to be, you're thinking it's about you. We want the pastor to be able to preach freely, right? But he was different. It was different, and he was acting in the capacity as a clinician, not a pastor. So sometimes you don't want to. You might not want to go to your pastor and tell the pastor, because you have to see your pastor every single week. And some things that we hear, it is a lot. And your pastor, you might be thinking your pastor is thinking about it. We don't want you to not come to church. We have clients who come to us and they share some things, and it is a lot. And then we have to know how to help them and navigate the embarrassment, or else they might not come back to therapy. Sometimes your pastor doesn't have the time or, even the expertise to kind of navigate that and ensure that you'll come back to church. Because of the embarrassment. There's a lot of embarrassment that comes when people share a lot.
Yeah. And that's one of the reasons we see that the telehealth is so effective, because it's taking away the stigma. We have seen less cancellation because people can just hop on in the comfort of their home. They can actually access it almost wherever they are. And they basically get the support that they really need. So what we really want you to take away from this, we just want to show you that it looks different in the black and brown community, but we just want also, as we close, for you to remember that Jesus has given to us, this church, a health care plan that is very, very effective in helping with depression, with helping with anxiety, with helping with mental health issues, right? That's one of the reasons for me, every day I make sure I do some exercise because it's not just curative, it's preventative. And Dr. Singh says the exercise is like the walking Prozac. You see, it's like the walking Prozac. In other words, it's equally or sometimes even far more effective in helping with depression. So don't underestimate the power of proper nutrition, the exercise, the water, the sunlight, trust in divine power. These things do help with our mental health as well. Does that make sense, ladies and gentlemen? All right. And so what we are going to do now is to just take a couple of questions, and then we have to close off here. So I hope whatever we share was very, very beneficial and helpful to you. All right. Any question? I know you had your hand up.
Pastor, when Jesus said, "Seek ye first the kingdom of God and his righteousness, and all these things shall be added unto you," what is your interpretation in simple terms?
My interpretation of seek ye first?
Yes.
The kingdom of God?
Yeah.
And all his righteousness and all other things shall be added unto you?
Yeah.
Yeah. Sure that whenever you lay hold on Jesus as your Savior, all the things that you need for your sustenance and survival is found in him.
Okay. Thanks.
Okay.
You know why I was late?
Mm-hmm.
Somebody was watching you today, like I was listening to you. And we were in a long conversation about you. That's why I was late. Thanks.
Okay. All right. Let's take Ella Kirk, and then we have another hand down there.
Pastor and Sister Brown, thank you so much, first of all, for this presentation. I am really, really happy for it. I will say this before I ask the question. I am noticing a shift in the church organization where certain things are now being addressed that were not previously talked about in the church. This is one of them. I know Dr. Fran Francis is doing something on finances,
Right.
which I think is really, really good
Very
for the
needed.
church.
Very
So
needed.
I'm really happy to see that, some attention is now being paid to some of these things. At the beginning of your presentation, you gave some statistics about, the percentage of blacks versus whites black and brown versus whites who will seek therapy.
Yes.
All right, and there was a 25%, I think it was, for the black
Yeah.
culture. I'm wondering how much of that has to do with finances.
Yeah.
You mentioned insurance,
Yeah.
but there are some families that do not have it. Some of us are blessed to have, jobs that
Right.
provide us with that. But for families that do not have insurance, what provision is there for them, that they can get the therapy that they may need?
No, and that's important, right? Because that's one of the challenges that people in our community face, the financial piece, the insurance piece. So what I know for us personally, and also for some of the other practices, there's a sliding scale that is offered to those individuals so that they can get the support that they need. There are individuals who come, they cannot afford the insurance, side of it, but when they hear about the sliding scale, sometimes we find that they capitalize on that, and that there might be other organizations out there who can provide them with that kind of support because they are getting the funding to make that available.
And there are also organizations willing to also pay for it. Like last year we had 2 people they came through, what was it, Rising Home? Darkness Rising.
Yeah.
And Darkness Rising paid for them to come to therapy, right? And it's for Black women who have had some engagement with the criminal justice system, not necessarily that you've been arrested, but you might have a child, a cousin, whatever. People don't know that. And they paid our full rate for the person to come to therapy. So there are organizations out there. There are times where you try to educate people as well. The person might not have insurance, but there are avenues of how to apply for Medicaid type insurance, which we do accept, and we'll kind of talk to them about that. And it really does take 2 weeks if you know what to do. So we'll kind of give them that information. Some people have insurance and still can't afford therapy. And that's something that nobody talks about, where you have insurance and in order for the insurance to cover therapy, you have to meet like a $7,000 to $10,000 individual deductible. You're pretty much paying for therapy the whole year. So, and maybe the last month in the year, the insurance will cover something. So there are a lot of people who have insurance and still can't access therapy, and some of those people, they're able to, tap into the sliding fee that we offer.
So that piece is also important. You are educating them the best kind of insurance they need to select if available, as opposed to those insurances that have this high deductible that you have to meet. Yeah. So I hope that answers your question.
Yes. Pastor and Sister Brown, thank you so much for sharing. It's such an important lesson for all of us. We are being educated, we are learning, and we will never stop learning as long as we live. As you're addressing the society, and now you talked about the church, and I was thinking, as leaders, we are all leaders, there are some cases that we feel because we are leaders or we are educated enough or we read a lot of white writing, we are practicing good health and what have you. And when it comes to leading and reaching out and connecting, I find that in some cases as leaders, we are emotionally disconnect, socially disconnect with the church and with members and what have you, and how devastating that could be, because I think that I know enough and I don't need help. And this has been some of my experience as I looked around churches, not just here, but our Adventist organization. Now we are coming to grips with certain things, and our church cannot grow or wouldn't grow in such a case of being disconnected emotionally, socially, and what have you. So how can you can help us as leaders that we can take this matter seriously. It's very, very important for us to take these lessons that you are sharing seriously, because not just as a society, the church is being affected in this area tremendously. And so how can we move on, or how can we as a people, because we pray, yes, and we do so many things, but yet we are lacking in some of these things, especially if I am broken as a leader and burdened and stressed. How effective can it be? Because I think all I need is prayer. You all pray for me, but I don't need help in that way. And that's the problem I find could devastate us in moving on as being good and healthy leaders.
Yeah, and that's where, as leaders, we have to recognize our lack. You know, in the plane, they tell you secure your mask first before you try to help another person. So in that case, if I recognize functioning, you know, I try to seek that kind of support for me as a leader, and it puts me also in a better position to be able to help another person. Getting awareness regarding the impact of mental health and its importance is always a welcoming thing to expose ourselves to as leaders. Recognize, you know, one of the things I also want to say, our leaders are doing a phenomenal job in terms of providing support, not just spiritual support, but emotional support, availability to many of our members when they come to us with some very, very everything. And we have been doing a tremendous job over the years with that. One person told me in the addiction certification course that I was doing, it says one of the reasons why a lot of people gravitate towards the chaplains inside the hospital is because they get a sense that the chaplains care. So a big part of therapy is a heart that cares. And when people sense that and you make that available, I'm telling you, that can be a blessing, right? And also, you know, recognizing again my limitation. So if a case is before me that is out of my ordinary praying and support, we might want to refer over that case to a professional for care. So seeking help for myself, constantly making myself aware, knowing my limitations, referring when possible, also providing support with a heart of care. Those things go a really, really long way. All right, if no further questions, on the behalf of myself. Yes. Okay. Yes.
I just wanted to emphasize, I heard you exercise and you try to stay physical. I'm also like that. I've been very physical and exercising since I was very young. I just wanted to emphasize on we're talking about mental health today. I love bike ride. Whenever I do a workout, it's normally 2 or 3 hours at least. At least.
Yes.
Swimming, bike riding, cliff jumping, you name it. I do a lot of things. And I just wanted to emphasize, last year, I remember, I went cliff jumping and swimming nonstop for a solid 3 hours. And I finished my workout and was going home, and I felt great. And I believe the chemical thing that makes you feel good is called endorphins.
Yes.
Okay. So after my 2 or 3 hour workout, I believe I was swimming that day and cliff jumping and doing all that stuff. My endorphin levels were peaking for 48 hours. So after my workout, I was feeling awesome.
Yeah.
For 48 hours before that started to wear off.
Right.
So I'm trying to emphasize, even if it's just 20 minutes a day or 30 minutes a day, you don't have to do my 3 hours a day, okay? That workout is going to get some endorphins flowing in your body, and it is the best medicine, okay? A strong workout. And let me tell you, after a strong workout, you're going to sleep pretty good tonight, okay? So you're not going to be losing no sleep. Your endorphin levels are going to be high. You're going to be feeling great. I don't know if you're going to be feeling great for 48 hours like I was, but exercise is important for mental health and also eating right.
Sure.
If you want to eat 5 junk, you're eating 5 things that are junk instead of eating 5 things like carrots and celery and potatoes, whatever. So if you're eating 5 things that are junk instead of 5 things that are very healthy for you, you're not going to be feeling mentally healthy. You're not going to be feeling good mentally because you just ate a plate of junk.
Yeah.
You'll be feeling mentally good if you ate carrots, potatoes, and celery and all that. So, I mean, your diet and exercise is so important on you having a good day today or you having a terrible day today, okay? And I'm so glad, like, I'm ready to, I can't wait until the temperature hits 85, 90 degrees because I got to get into that water.
Yes, sir.
Yeah, okay? So basically, you know, work on your exercise, work on your diet, and it's definitely going to improve mental health.
Sorry to cut you off.
Yes, no, that's all I have to say.
Yeah. No, I concur with you 100% because there's something out there as nutritional depression. If you're deficient in certain essential minerals and vitamins, it can lead to depression, especially. That's why your grains, your nuts, you know, like your B12 vitamins, your omega-3 fatty acid, if you are deficient in those, it can trigger depression. So a healthy nutrition definitely will help with depression. And as the gentleman was saying, exercise, something physiologically happens within your body. Not, you know, as he mentioned, endorphins, but there are neurotransmitters that are responsible for keeping your mood stabilized. These are produced by proper nutrition. So if you're not getting the nutrition to make them, you're going to be in trouble. If you're not moving, that your body was created. Because remember when God created Adam, he gave him the garden to keep so he was getting physical exercise, even in a perfect state, because something physiologically happens within your body when those things. So you cannot underestimate the importance of those things. You can't be functioning on just 3 hours of sleep, 4 hours of sleep, and expect that you're going to fight fatigue and depression. It doesn't work. So getting adequate sleep. But that's in another presentation that we do, because we cannot do everything in one go. That is why for our main focus is just to show that the language is different when it comes on to us in expressing depression. But in another presentation, we actually walk through how exercise, water, sunshine, temperance, air, rest, trusting divine power, these things help. By the way, did you know Ellen White calls them God's 8 doctors? 8 doctors. Why? Because they work upon the body as doctors. Scientifically documented that when you get adequate exposure to sunlight, what it does to your body. All right. In Alaska, you find that the depression, the suicide rate is high. Why? Because majority of the year, the sun is not out. So you know what they have to do? They have to have these these light bulb, these bright lights where people can go and expose themselves in order to combat the depression rate there. That's how significant sun exposure. And we could get into all of that, but we just can't do it here this afternoon. So ladies and gentlemen, you know, you live in the capital here. Bless the name of the Lord. We have at least 1 hour and three-quarter journey travel, but it was a pleasure, a delight for my wife and I to have been here with you today. And we just hope that our interaction today, there are things that you certainly will be able to take away and to use. All right? So God bless you. Pastor Coleman, thank you for inviting us. Sister Ains, thank you again for inviting us. If you want to have any understanding or seeking an outlet, my wife is the clinical director of the practice. I turned that part over to her. And so she's putting up her contact information up there. If you need help or you need support, you can definitely look at that. All right? Thank you.
I really want to thank Pastor Brown and Sister Brown for being with us today. It was very informative. I would say if you don't think so as well, it was very informative. And I will turn the rest of this over to Pastor Coleman.
Thank you, Sister Bev. And Sister Bev has, has done a good job in coordinating. And we are blessed. You've served in this department before, and you continue to serve, and we appreciate your dedication to health and to coordinating health ministries in the church. And we've been blessed today. I think, and blessed in terms of the fact that we received some very useful information. And one of the things I got from this presentation is that, hey, when you have certain challenges in mental health, you can get some help that will protect you in the workplace. You know, and I think that was very important to let people know that, hey, there are other people that are not in the minority race or culture in the United States that have some issues, and they get help. Yes. They know how to access help, and that we in the black and brown communities, we have to know how to access that help for our protection. So I think the information was on point, thorough, and very informative. So again, let's give a round of applause to Pastor and Sister Brown for the fine job that they have done in presenting, and your little daughter was helping out as well, passing the microphone around. Well, we just want to extend a little token of appreciation. We know you're a conference worker, and you will do this without a token. Yes, yes, sir. But we just want to thank you for taking the time, especially both of you, in the afternoon here to do this workshop. And certainly we were enlightened, and the word that they're using now, elevated, as a result of your presentation. And may God bless you, and may you have a safe trip back. All right. Thank you so much. Thank you so much. Well, let's stand together. The sun has not set as yet, but we want to just, that's mine. We want to close out, and then we'll leave the time up to you to take advantage of the rest of the Sabbath. Many of you will be heading home, but we're going to close out now. Would you please bow your heads as we seek the Lord in prayer? Loving Heavenly Father, thank you for this time, this very productive, restful, and healthy time that we have spent in your courts. We thank you for Pastor and Sister Brown for the wonderful, informative presentation that they have made. Now, O God, we want to be able not just to be good hearers, we want to be good doers, so that we can reap maximum benefit from the information that was presented. And so, Lord, we pray that you would bless us, that you would allow your face to shine upon us this week and in the days to come, and help us to live in peace with good mental health and physical health, and of course, spiritual health. We look forward to the day when Jesus, the one who can give us peace and encouragement, the one who has died for us, will come back to take us home, and we will live in his presence, and there'll be no more trouble. We won't need mental health therapy. We won't need any kind of medicine, because we will be well throughout the ceaseless ages of eternity. Thank you for hearing and answering our prayers. In the precious name of Jesus Christ, amen.